everyone, this is Nguyen. Today I'm going to go over some common X-ray imaging that we see in the ER and, some cases associated with it just to make it more interesting. Next slide, so some disclosure and disclaimer. Next slide. These are some basic terminology that you can look into, but most of you, already know this. So next slide. A comparison. We're going to go over basic chest X-ray, first, and all of this is all X-ray imaging, not CT or MRI or also ultrasound. So this is just a normal chest X-ray with some terminology and landmarks. Next slide. So case one, we often see this in the ED. You have a 3-year-old with cough, worse at night, and other upper respiratory symptoms, and he have like a bark-like cough. So when you come in, he'll cough, and then you hear this bark-like, and you're like, oh, it's probably croup. So most common between 6 months to 3 years old, and in the winter. And most common cause is the para-influenza, even though other viruses can cause it as well. And the bark-like, seal-like cough is due to inspiratory stridor, due to swelling of the upper airway. You don't have to get an X-ray for this to diagnose. This is more clinical judgment. But on the X-ray, you will see the steeple sign due to airway narrowing. And the treatment of this is, of course, steroids, Decadron, 0.6 mg per kg, time only 1 dose, because, Decadron will last for 3 to 4 days. And if it's bad enough where they have some sort of, respiratory difficulty, you would do racemic epi-nebs. And if they require more than 2 nebs, you should really admit them and watch them. And then plus or minus, supplemental oxygen. Cool mist before have shown to maybe be effective, but this anecdotal, I think there was some study that didn't show any support to it. And then there's definitely literature about Heliox. Heliox is oxygen and helium. It depends on the concentration. Usually most ER or most hospital will have the 50-50, 50 oxygen and 50 helium. But, some places will have like more of helium than oxygen. And it's actually really good for upper airway obstruction because the helium can carry the oxygen through much better than oxygen and nitrogen. So it's something to, be aware of and have if your facility have it available, especially when they have, in need of severe respiratory support. So case 2, 2-year-old with respiratory difficulty, sore throat, fever, drooling, not eating, coming in, kind of tripoding, and you're like, oh no, this is bad. This is probably epic-hepatitis. Most common cause would be your strep and staph. It used to be H influenza, but now with, like I say, with the vaccination issue, you see a rise of H influenza and pediatric epiglottitis. And it's generally rapid onset. And if they're drooling and they're tripoding, that's very concerning. You do not need an X-ray for this, and please do not get an X-ray. Call your surgeon or your anesthesiologist right away and try to get an airway in a controlled environment. So the management would be secure the airway, start them on antibiotics. Oftentimes though, if they're coming in like this and if you have time, it's suggested that you don't even try to get an IV in them and try to agitate them. Because if you agitate this patient, they can go from a partial airway obstruction to a complete airway obstruction, and you'll be in deep trouble. So usually for this, you call anesthesia, surgery, and ENT right away, and they can do everything in the OR to secure that airway and get labs and start them on antibiotics. But if you do want an X-ray because you're not sure, there's a thumb sign on the lateral view because of the swollen epiglottis. Case 3, also pretty common, very common actually, other than croup, is a 1-year-old with cough, congestions, respiratory difficulty per mom. and the patient presented with tachypnea, but otherwise looks okay. And you're like, oh, you know, and you don't hear anything in the lungs, and you're like, oh, this is probably bronchiolitis. So it's usually less than 2 years old, and it peaks around 3 to 6 months. 80% is due to RSV, but the other 20% can be other respiratory viruses. They can get fever, but the hallmark would be the congestions. You know, these patients are severely congested. And generally when kids are less than 2 years old, they breathe through their nose. And so when they get congested, you know, they have problem breathing. That's why they have respiratory issue. You know, you can get an X-ray to rule out pneumonia, but what you'll see is peribronchial, you know, thickening. If you look at the X-ray on the right, you'll see that in the circles. The treatment for this is supportive, aggressive nasal suctioning, O2 supportive, me too, and admit them if they're less than 6 months because of apnea. These patients can become very apneic during sleep and can actually die from it. It wasn't a patient of mine, but during a shift, you know, an ambulance did brought in a patient that was coded, and she was like about 6 or 7 months. And it was from this. So if they're less than 6 months, you know, particularly 3 months, you gotta admit them for observation and make sure they don't have apneic episodes. In the past, we have used, steroids and bronchodilator, but studies have shown that they're not very effective unless they have wheezing on exam. So next slide, you know, this is kind of like the differences in terms of where the issue is in the airway. Okay, next slide. So you have a patient, 82-year-old with fever, confusion, labor breathing. You get an X-ray and you find a lobar pneumonia on X-ray. So with pneumonia, community acquired versus hospital acquired. Hospital acquired, of course, you got to worry about MRSA and Pseudomonas. And then for the patient with dementia, you worry about chronic aspiration, so you worry about anaerobes as well. Community acquired, the most common would be your strep pneumo, I would say about 70 to 80%, and then your atypical with, you know, mycoplasma and mozzarella. And then H influenza is also common too. The mortality really depends on age and comorbidity. And some of the prognostic score that we use for community-acquired pneumonia, whether they can be outpatient versus inpatient, you know, a lot of this is just kind of like your clinical suspicion. You don't have to use this score, but there are scores out there that, you know, that I want you to be aware of. The Curve 65, base it on, you know, mental status, the creatinine, the BUN and the creatinine, the blood pressure, the age, and the respiratory. The source score is, you know, based on their oxygen requirement, the blood pressure, and the pneumonia severity score, or the port score, is kind of like this, you know, the same thing. With each score, it shows you whether the patient is moderate or severely sick and whether they should be inpatient, outpatient, and whatnot. But like I say, you know, use your clinical judgment to see whether they can be managed outpatient or they should be admitted for observation at least. So in the next case, you have a patient that fell and complaining of chest pain and some shortness of breath. And on exam, you find asymmetrical, breath sound. And of course, you worry about pneumothorax. If the patient is not in, you know, respiratory distress and they're not hypoxic, you know, you can, and you have time for an X-ray, go for it. You know, get an X-ray to confirm that diagnosis. But if they're hypotensive and hypoxic and in distress, you know, your suspicion should be high, especially on exam if you feel like if there's crepitus or if you feel like, you know, there's step off concerning for rib, you know, fracture, then you should really, you know, stick a needle in to decompress them. The other thing too is because oftentimes, even with a portable, you know, and for these patients, you should not send them to the department for X-ray. If you get an X-ray, get them, you know, get a portable. And then, you know, if you don't have time, because it does take time for the tech to come in with the portable machine, put a probe on them. The ultrasound have shown to be more sensitive than X-ray in detecting pneumothorax. So put a probe on them, you know, put them on the apical from, you know, the clavicle all the way down, and to see if there's any abnormality. You know, in terms of abnormality, you should really, so you can put them in regular mode. If you don't see sliding of the lung, that's a concerning, that's what we call a lung point, and that's pretty much sensitive to a pneumothorax. Because if they're sliding, hold on. Hello?
2, 1, and hold yours.
Yeah, so if you see the lung sliding, you know, you're good. But if you don't see the lung sliding, you see a lung point, you know, that's, you know, very highly suspicious for a pneumothorax. However, you have to be mindful for people who have COPD or emphysema, they can have boli, and that area is not going to slide. And so, you know, and that could be normal for them. So, you know, take everything into account. And also if they have, like, you know, especially if they're laying down and they have, you know, pulmonary edema and all that, and their lung is not moving that much, you know, or they severely hyperinflated from COPD or asthma, and, you know, their lungs are not going to slide. So that doesn't mean 100% that they have a pneumothorax and their lung doesn't slide. And the other thing too is, so that's just the regular mode, and then you can put them in the M mode. And the M mode, it tells you whether there's movement or not. And then in the M mode, if it looks like, you know, like kind of like a seashore, and this is what you hear, seashore, you know, where it's look grainy, then that means there's motion, and then you're good. But if you don't see motion and you see like a barcode, you know, kind of sign, then that's pneumothorax and too proven. So I use the regular mode where you look at lung site, and then use the M mode, the motion mode, to see if there's any signs of pneumothorax. And then after that, do needle decompression, or, you know, stick in a test tube. Before, they say if you have tension and you do the mid-axillary line needle decompression them at the fore-intercostal space. You know, these days they have shown that even if you can do a chest tube quickly, you should do that. Or if you do needle decompression, you should do the mid-axillary rather than mid-clavicular, and do decompression at the mid-axillary, and then after that, stick a test tube in there. So there's no point of doing mid-clavicular needle decompression and turn it into mid-axillary chest tube placement. For me, if I suspected and they're like, hypotensive and hypoxic, I just do a quick chest tube and decompress that, one. So that's pneumothorax. Next slide. So a patient got tackled or fell and have shoulder pain, and then the shoulder doesn't look deformed, but you notice that the clavicle is a little deformed, and there's tenderness on the when you palpate the clavicle. So you suspect a clavicular fracture. So you get an X-ray and it shows a fracture. The most common would be your middle third, which is group 1, and then group 2 and 3 are kind of like not so often. When you have a clavicular fracture, make sure you look at the lung parenchyma too. Make sure there's no pneumo. Next case, a person that fell on their shoulder, and then you get an X-ray. They have limited full range of motion. The shoulder doesn't look deformed, but there's like a little bump, and that's tender where the AC joint is. And you get an X-ray, and you see a separation. Normal AC joint should be less than 5 millimeter when you measure it. Greater than that, you should suspect a separation. Generally for this, you sling them, and then you get surgery if it's group 3, just because they're unstable. And it is categorized by the ligament that it's involved, and you can look at the anatomy of the shoulder, the ligament on the right hand side and also below. Next case, you have an 18-month-old that come in with right arm pain. The moms say, or the parents say, fell out of the bed, and you notice bruising. And you get an X-ray, of course, and it's spinal fracture, and you get a skeletal survey as well to make sure there's no other fracture. So when you have a toddler or anybody, any kids below, I would say below 4 or 5, but I think the threshold is like less than 2. But any kids below 5 and they come in with like a weird fracture, I would suspect, child abuse and call social, service to make sure that it's not the case. But this is often missed, and the child end up being dead because of the abuse. So we got to take this very seriously. Okay, so we have a 13-year-old that fell, and she had swelling of her elbow. And then you get an X-ray, and on palpation, she's painful. You get an X-ray, and you see fat pads, anterior and posterior. So, when you see this, you guys suspect condylar, supracondylar fracture. Kids, especially this age, should not develop fat pads. So fat pads are when the bone is elevated and the fat is, elevated as well. And that's causes shadowing in the X-ray, the dark shadowing in the X-ray. You can get, this is posterior and anterior, and generally it's less than 10 years old. Like I say, it's peak around 5 or 7. If it's around that age area, you got to make sure it's not abuse as well. And the mechanism is generally a hyperextended elbow. If you miss this and you don't call ortho for follow-up, they can develop, nerve injury and deformity of the humerus and forearm. The treatment for this is generally, if it's an obvious supracondylar fracture, then you admit them, get surgical evaluation, and they cast them up after. For a lot of these cases, if you just see fat pad, you should really consult ortho, make sure that they're okay to go home and follow up. So what I generally do is forward the X-ray for them and let them see. So next case, patient fell, an outstretched hand, and now with wrist pain. Very, very common fracture, the Smith fracture, which is volar angulation. And these fracture are distal radius fracture, and we call them based on their angulation of distal radius. A Smith fracture is not as common as the Coley fracture. The Coley fracture is more common. It's about, I would say, about 90% of the wrist fracture. And the Coley fracture is a dorsal angulation, and the Smith fracture is a volar angulation. And the way you treat this is cast or surgery for fixation. Next slide. So you have a patient with a fist fight and they come in with like a painful and swollen knuckle. And you look at it and it's, the 5th knuckle, and you're like, oh, this is probably a boxer fracture, which is a distal fracture of the 5th metacarpal. And it's the most common metacarpal fracture. It can involve the 4th metacarpal as well. Generally for these, you got to splint them and depend on the angulation, whether it need reduction or not, or surgical pinning. If there's greater than 70% angulation, they need pinning. If they're, greater than 40, degree angulation, it's a hit or miss. Ortho would decide. If they don't get splinted or pinned, surgical pinning, they can develop long-term deformity and use of that hand. And so, you gotta, make sure, the least is split them up and send them to ortho with close follow-up. Next slide. So you have a patient that, was skiing and then fell into her hand, right hand, and she's coming in complaining of hand pain, mainly at the base of the thumb. This is the gamekeeper thumb or the skier thumb, and it's not really a fracture, but it can have an avulsion fracture, but it's more of a ligament injury, and it's the ulnar collateral ligament. And it's usually the first, the first metacarpal, which is the thumb. Mechanism is hyperextension of the thumb. On X-ray, you can see an avulsion fracture, but you'll see, like, as you see on the upper right, a little sliding of the metacarpal joint. So the way you treat this is, thumb spike and split it up in orthoreferral. If it's a complete rupture, then internal fixation. If it's incomplete, then 4 weeks of, splinting. Next slide. You have a patient, a volleyball patient with knee pain, chronically for the last 4 weeks. No direct fall or direct injury. Pain worsened with going up the stairs. And on your evaluation, there's, point tenderness over the patella tendon, particularly at the tibial insertion. You get an X-ray, most often the X-ray will be normal, but if it's, chronic enough, you will see some calcification at the insertion of the patella, like a white, shadowing at the patella tendon. This is called the jumper knee. This is, for athletes who use their knee a lot and, have a lot of impaction injury where they jump up and down or like use their knees a lot. And usually you have pain over of course, the patella tendon. The way you treat this is strengthening exercise and physical therapy, particularly the quads, to try to strengthen the patella tendon. And of course, rest. Next case, ballet dancer with lateral foot pain. So foot injury, particularly the fifth metatarsal, it's categorized by where the the fracture is. So what we worry about is Jones fracture. And if you look at the illustration on the right, Jones fracture is the proximal fifth. And it's usually, 2 to 3 centimeter distal to the tuberosity. And the reason we worry about this fracture and it needs ortho referral is that, it's prone to non-union. About 30 to 50% are non-union and need pinning. So if they follow up with ortho and X-ray and it looks fine, non-weight bearing cast for 6 to 8 weeks. But if they're, if the X-ray doesn't look any, better, they have to take them in and actually pin it down. The other fracture, which is the more common, is the Suter-Jones fracture, is when you have an avulsion fracture of the base of the fifth metatarsal. And it's usually the peroneus brevis tendon avulsion injury and not actually in a fracture. And 90% of it is, the fifth metatarsal. And for this, you just put them on a shoe. Next case, you have a patient that jumped down a wall and complained of heel pain and a little bit of back pain. So calcaneal fracture is due to severe axial loading. When you see these fracture, ask the patient if they have, and palpate their lumbar spine, because 10% of these fracture are associated with lumbar vertebral fracture as well. And oftentimes, if the mechanism is enough and the X-ray of the calcaneal is pretty comminuted, I get a lumbar X-ray anyway. So far, I only catch one case where the patient was totally asymptomatic in terms of back pain, and there's like a small fracture of the vertebral body. If a patient is unable to bear weight and there's swelling of the heel, you should worry about compartment syndrome or Achilles tendon injury as well. The heel doesn't have a lot of space, so make sure that you assess for compartment syndrome. There's others. When you get an X-ray, you can do the Bowler or the Dison, measure it out. But for me, if the mechanism is high enough and they have pain with weight bearing, you should get a CAT scan. Even if they have a fracture of the heel, a lot of time, next slide, when when you refer them to ortho, they get a CAT scan anyway to classify it. So there's two classification, the ASIT and the standard classification. Oftentimes, ortho use the standards classification, and it's based on CT, so they get CT anyway. And what you look for is intraocular involvement or not. If it's no intraocular, interarticular, involvement, then you do ortho boot, non-weight bearing, and they put them on a cast, for a while. If it's interarticular, and based on how bad is the fracture, on a CAT scan, most usually require surgery within 1 week when swelling goes down. If they don't get surgery, or if you miss this fracture, if you, like you say, get an X-ray and you don't measure the lines and you don't see a calcaneal fracture and they go home, there's risk of deformity and gait issue long-term if this is missed. So, like I say, if X-ray doesn't look and they can't really bear weight that much, and especially with their mechanism of injury, get a CAT scan. Next slide. You have a patient that fell or was involved in the MVC and now complaining of neck pain. So a hangman, so usually before, in the past, we would just get regular chest, X-ray of the cervical spine. Now we just go directly to CT, right? And you get a CT and you see a fracture of C2. So this is an injury, it's called the hangman injury. It's a hyperextension high velocity injury. And it's usually in your elbow, and the sliding of the C2 on the C3. And this oftentimes fracture of the bilateral pars. And it's considered an unstable fracture because of C2. And for this, you definitely cervical collar them, consult your neurospine or neurosurgery for immediate follow-up. If there's no surgical involvement, they put them in a halo traction for a couple of weeks. But oftentimes, these patients will need surgery like fusion and fixation. Next slide. So you also have this is a patient that came to you with neck pain after diving into a pool. And there's, he say that, he has some pain and some issue with, temperature, like feeling hot or cold. You get a CT spine, again, and what you see is a fracture of C1 on C2. And then you can see, on the CAT scan, you can see the displacement of the lateral masses. But if you get a normal, regular X-ray imaging, which I'm not sure why, these days, unless you have no CT imaging capability, at your ER, then you get an X-ray. But on the X-ray, you will see, displacement of the lateral masses, which is, what we pointed out in the red in the X-ray on the right hand. If there's more than 2 millimeter displacement, then you got a concern about, a burst fracture, and 15% are, associated with core injury. And the prognosis and whether you do surgery or not is based on the transverse ligament. If it's intact, it's stable. If it's not intact, then it's unstable and requires surgery. Next case, NVC with back and belly pain, restraint, driver, high speed. When you have a restrained driver and they have belly pain and back pain, you of course get a CAT scan of the CT of the abdomen and pelvis, and you can tell your radiologist to reconstruct so that you can see the thoracic and lumbar spine too. Because in these patients, right, you worry about chance fracture. I mean, if they have abdominal pain with trauma, you worry about abdominal injury. But at the same time, instead of like doing a dedicated lumbar spine, you can tell and reconstruct so that you can see the spine as well. A chance fracture is when you have both, when you have a fracture of the lumbar spine. It's what we call the seatbelt, injury fracture. It's an flexion extension, injury fracture, and it's unstable. When you have this fracture, you've got to rule out intra-abdominal organ injury, particularly, bleeding in pancreas and liver, and also, bowel contusion. The most common site of this injury for the spine is the lower thoracic and the upper and even lower lumbar. And usually these patients, just because of the location, they usually, knee surgery, fusion for the spine as management. If they're stable and it's not severe, they can be placed on a thoracic lumbar, TOSO brace to stabilize the fracture. Next slide. So you have an elderly with osteoporosis complain of low back pain, but no injury. So this is actually pretty common in elderly. It's usually an axial load. It doesn't have to have a high, mechanism of injury. They can just, get out of bed or like sit down, quickly, and they develop like, a compression fracture. You can get an X-ray on this and see the compression. But if they're in severe pain, you should get a CT or if you can, get an MRI, but that's more outpatient, just to quantify the height loss of the compression. If it's greater than 45% height loss of the vertebral body, they probably will need some surgery, either a fusion or like what they do with the kyphoplasty is inject like a cement to, improve the compression deformity of the vertebral body. But oftentimes you can do a TOSO brace for like 4 to 6 weeks, and they generally do well with that. Next, so you have a elderly with nausea, vomiting, and abdominal pain, and no bowel movement recently. They're not on like pain medication, and their belly is distended with not a lot of bowel sound. So you worry about bowel obstruction. If you worry about and if they're distended, I would go, and a lot of providers would vouch for this. You go straight for the CAT scan and not get a CT and an X-ray. Go straight, unless you worry about perforation, right? If they're really tender, distended, and you get a quick bedside X-ray to rule out free air, because if there's free air, just call surgery and get them, in the OR. But if they're stable and no peritoneal sign, then you get a CT to rule out the obstruction. So there, the most common would be your small bowel obstruction, and then then you have your large bowel. If you get a regular X-ray because you're not very impressed and it shows that there is dilation of the bowels, the way you differentiate between the large and the small bowels is that small bowels tend to be central, the dilated bowel loops, and then large bowels peripheral. And the diameter of the dilation is not as great in the small bowel as the large bowel, of course, because the large bowel is it's bigger. And then you'll see the haustra in the large bowel, which is the connective tissue is not all the way across, whereas in small bowel it's directly across, where the arrows is pointing into the in the below X-ray illustration. And then in small bowels you'll see a lot of air fluid level, which you don't really see in large bowel at all. The treatment is almost similar because you decompress the obstruction. You put an NG tube in to decompress the bowel, and if it's if that doesn't improve, and if it's a large bowel, you do a rectal tube to decompress the bowel, and of course NPO. And if it's medication induced, you try to reverse that, and of course admit them and get surgical evaluation. Majority of the case of these bowel obstruction, unless they progress to ischemia with a high lactate, it's not a surgical case, it's a medical case, but you still get surgical involvement. in case there's no resolution and they have to go to the OR to have surgical decompression. But generally with small bowel and large bowel, they do well with decompression with tubes, either NG tube or rectal tube. And then what we usually do too is get daily X-ray to see if their bowel obstruction or the dilation has improved. And keep them NPO, of course. That's pretty much it. I mean, there's other common stuff, but they're not. These. We can go on forever, but these are just the basic stuff that we commonly see. If there's any questions, please let me know. Thank you.